Okay, good evening and welcome to our Learn and Share conference call. I'm Russ Derry, the Director of Education for Epilepsy Foundation of Michigan, and I'll be moderating this discussion. The topic for today is headache and epilepsy, and we're very pleased to have as our speaker Dr. Lalitha Sivaswamy, who's a pediatric neurologist at Children's Hospital of Michigan. So could you briefly introduce yourself and talk a little bit about your clinical and research interests and describe your experience with this topic?
Absolutely. Hello, everyone. As Russ said, I'm a child neurologist by training, and I've been working at the Children's Hospital of Michigan in Detroit for the past 15 years or so. And I was a pediatrician before I started my life as a child neurologist for about 6 years. And I currently spend about 60% of my time in clinics seeing patients. And the rest of my time, I'm a clinical researcher, and my areas of interest are headache, especially in the pediatric population. But of course, being a pediatric neurologist, I also see quite a few families whose children have epilepsy.
Okay, great. So people with epilepsy are more likely than the general population to experience migraine or other forms of headache. So before we talk about the nature of this association, can you give us an overview of the most common or notable forms of headache and kind of briefly touch on the various causes and symptoms of each?
Absolutely. So as Russ rightly said, epilepsy seems to predispose individuals to migraine, no matter whether they're a child or an adult. And the most common forms of epilepsy most common forms of migraine, that we see in individuals with epilepsy are what we call tension-type headache, migraine headache, and peri-ictal headaches. And Russ, shall I go ahead and talk a little bit about each type at this point?
Sure.
So tension-type headaches are, the most common form of headaches. All of us have experienced it at some point. But the name is a little bit of a misnomer because people hear the word tension and they think it means stress or anxiety, and it doesn't. In this context, tension refers to the tension of the muscles in the forehead and in the temple and probably in the neck and the back of the head. And it's a very common form of headache, but individuals with epilepsy seem to have a higher incidence of it than the general population. The second most common type is migraine. And migraine headaches are much more severe than tension-type headaches, and it's not just a severe headache. It's often associated with some vomiting. Sometimes you may just have a queasy belly, even if you don't vomit. Some individuals have a lot of sound and light sensitivity, and sometimes sensitivity to smells. And oftentimes a migraine headache can last several hours, and it can wipe the person out for the rest of the day. So they can be fairly debilitating, and unfortunately, they are quite common in individuals who have epilepsy, much more common than in the general population. And finally, there's a specific type of headache that occurs in individuals with epilepsy, and we call that peri-ictal headache. And the word peri means in the vicinity, so it may be just before the seizure when we call it a pre-ictal headache. It may occur after the seizure when we call it a post-ictal headache, or the headache itself can be part of the seizure, which can make it very confusing for families as well as for physicians because it's kind of hard to differentiate the two at that point. Peri-ictal headaches are relatively uncommon, but there are certain epilepsy types which seem to predispose to it. But on the whole, of the three, the most common in folks who have epilepsy would be migraine headaches.
Okay. And as far as some other types of headaches that, can be classified, are most of the other types of headaches that people might think of like sinus headaches or cluster headaches or hypertension-related headaches? Are those just less common, or do they fall under different specific categories? Can you talk a little bit about any of those other types?
Sure, absolutely. I'm glad you mentioned sinus headache, because that's something which seems to be a fairly common diagnosis, which all of us make for ourselves. And oftentimes I'll have a family who comes in, and the child may have headaches, and the father will say, well, I've had sinus headaches all my life. But when I actually inquire and sit down and talk to the father about the headaches he had in his childhood and in his early 20s and maybe 30s, I realized that they're actually migraines. So there's often a misconception that a sinus headache can lead to chronic headaches, which is somewhat unusual. Now you mentioned cluster headaches. Cluster headaches are one of the rare types of headaches that's more common in men. Migraine headaches and tension-type headaches, for some reason, are more common in women, but cluster headaches have a male predilection, and they're not necessarily more common in individuals with epilepsy, and they tend to have very, very characteristic features. But since this talk is mostly about epilepsy and headache, I'm not going to delve too much into cluster headaches.
Sure.
And the other types of headaches that a person can have related to hypertension, again, not closely related to epilepsy. But sometimes individuals with epilepsy, they are, as prone to developing other diseases as anyone else. And so sometimes I will see headaches related to glaucoma, or headaches related to a venous clot in their brain, or headaches related to a pathology involving the arteries of the brain. But that's not the norm. That's more the exception rather than the norm. And probably having epilepsy at that point doesn't necessarily make it more likely for you to have those types of headaches.
Sure. Okay. So we mentioned peri-ictal headache. So in the case of pre-ictal headache, is it ever reliable enough to allow some sort of intervention to try and prevent the impending seizure?
Oh, that's a great question. Yes. Some of my patients will say, you know what, I almost never get a headache. It's unusual for me to have a headache. But when I get one, I know that a seizure is coming on. And sometimes, individual can actually predict that the seizure is going to happen within a few minutes of the seizure, of a headache coming on. It is somewhat unusual, and though interestingly, research studies have shown that blood flow to the seizure focus seems to produce a headache in the involved region of the brain. So even though the brain itself has no pain fibers, the meninges or the coverings of the brain may be more swollen just before a seizure, and therefore the individual may be experiencing it as a headache and thereafter may develop a seizure. But how reliable is it? That's a good question, and we don't have a lot of literature to conclusively prove that doing X or Y just before your seizure when you have the headache is helpful. But if a given person realizes that their headache is a strong predictor of having a seizure, that would be the perfect time to pull over if you're driving, to get away from the stove, or if you have a baby, to put the baby down, to sit down closer to the floor or in a chair which has armrests. So taking precautions of those type would be definitely advised. And if you have access to a rescue medication, making sure it's close by or alerting somebody, more importantly, would be something that I would advise.
Okay, great. So how common is it for a headache to be a side effect of anti-seizure medication? And what are some clues that can help to differentiate headache as a side effect versus headache from other causes?
Well, yeah, anti-seizure medications as everyone here probably knows, can have a wide variety of side effects. And if you look at the pamphlet that the pharmacist gives to you when you pick up your seizure medications, you may notice, a long laundry list of side effects, and the headache is always going to be there. But if you pick up an antibiotic, a headache is going to be mentioned as a possible side effect. In terms of specific drugs, in fact, many headache medications can be protective for a headache, and they may actually prevent a headache. But I have a lot of patients who say that if they stop taking their seizure medication, or if they forget to take their seizure medication for a day or two, they will often get a rebound headache related to that. And one of the medications which patients have reported to me, which may be causing it, is Onfi or clobazam. Now, these are anecdotal reports. I haven't seen a lot of literature to support it. But yes, I would say that probably stopping seizure medications abruptly is more likely to precipitate a headache. But, as we go further in the discussion, I'd be happy to talk about which seizure medications can actually help with your headache. So if you have both epilepsy and migraine, or epilepsy and tension type headaches, there are some very suitable choices out there.
Okay, so as far as anti-seizure side effects go, like the most common ones, you wouldn't think of headache as being one of the most common anti-seizure medication side effects?
No, I would say that by far, I think the most common side effect would be drowsiness or sleepiness, especially when you first begin to use your medication, because there's an acclimatization period, and that may last for a few weeks. So those would be the more common side effects. But headache, yes, I agree with you, would be a less common one.
Okay. So are there significant differences in symptoms and management of headaches in children versus adults with epilepsy? Yes,
there could be. And for instance, some children are too young to express their symptoms, so they may just look pale during their episodes. They may look sweaty or flushed. Sometimes they may have a quote-unquote fever, so the mom or dad may say, my child feels really warm, but when I check their temperature, they don't appear to have a temp. They may act like they're in pain, though they may not be able to express the symptoms, and children tend to have more vomiting and more motion sickness for some reason. Children with headaches, especially migraine, also tend to have what we call autonomic symptoms, symptoms of being lightheaded, palpitations, and those types of symptoms are very common in children. On the other hand, adults who have migraine tend not to have a lot of vomiting, but they can have nausea or abdominal pain. Some of them may have an aura. An aura is very uncommon in children. It's rare to have a child with migraine who has an aura. I would say less than 10% of children have it. On the other hand, quite a few adults who have migraine do have an aura. And adults with migraine, their headache tends to sometimes be precipitated by very specific triggers, which is uncommon in children. For instance, an adult may say, if I eat certain types of cheeses, or, if I, eat lima beans, or, the sprinkles on a cupcake, the red dye, or maybe MSG in Chinese food, or, those types of things seem to be more predictable triggers in adults, whereas in children, it's rare to have either a food trigger or an environmental trigger. Another thing I've noticed is that adults tend to have migraine sometimes when there are changes in barometric pressure. Today would have been an example when a storm is just about to move in. A lot of adults will say that, oh, I know I'm going to develop a migraine headache. But one factor that's common to both children and adults who have migraine, in association with epilepsy or even without, is sleep deprivation is a strong trigger.
Okay.
For instance, teenagers will say, well, I only sleep for 6 or 7 hours on the weekdays, but I make up for it on the weekends by sleeping 14 hours a day. But that's not really good, because your circadian rhythm is then disrupted, and any disruption in your sleep-wake cycles tends to trigger migraine, no matter whether you're a child or whether you're an adult.
Right. And I guess when we talk more later about treatment options at that point, as we're talking about treatments, maybe if there are any key differences between treatments for adult and for children, maybe you can point those out at that time.
Oh, absolutely. I'll be happy to discuss that.
Great. So under what circumstances would a headache be considered a medical emergency?
Yeah. I mean, there are certain situations, and one classic one is what we call a thunderclap headache. So it's a very descriptive name. It comes on very suddenly. So it starts, and you're at a 2 out of 10 a few minutes ago, and now 10 minutes into the headache, and you're at 10 out of 10. So that type of rapid increase in pain, or the thunderclap headache, can be very suggestive of certain serious disorders. And of course, the most common of which, especially in an adult, would be a aneurysmal rupture. And that would lead to a certain type of bleed in the brain. It's called a subarachnoid bleed. But that type of thunderclap headache is fairly suggestive of that. Of course, there are other causes for a thunderclap headache, such as clotting off some of the veins in your brain. There is a condition called dissection, and interestingly, individuals who have migraine have a predisposition to dissection. And dissection is a condition where there's a tear in the wall of the blood vessels, and so the blood kind of tends to seep out of its normal compartment. And it can follow a fairly trivial injury. I had a teenager who was playing hockey, and he really didn't remember getting hit by the puck, or he didn't have a concussion, but he might have, quickly twisted his neck to look in another direction, and he had a dissection after the game. Sometimes you have dissections when people are painting the ceiling, and their head is kind of bent back for a long period of time. So, yeah, sometimes we see thunderclap headaches in association with that.
Okay. So what do we know about the prevalence of migraine in people with epilepsy and vice versa?
Yeah, it's interesting because, in fact, in the past, there used to be a term called migralepsy, which, a lot of neurologists have stopped using nowadays. But I think it's an interesting term because it kind of indicates that there's a continuum between migraine and epilepsy. And there may be factors that are causative for both, and there could be symptoms that are very similar to both migraine and epilepsy. Treatments can be shared. So it's a pity that that term has kind of gone out of vogue. But nonetheless, so individuals who have epilepsy are probably about 3 times higher, have a 3 times higher rate of developing migraine compared to the general population. Now, of course, we have to remember that migraine is a very common condition. About 22 million women in the United States have migraine. About 6 to 8 million men have migraine. So it is a common disease, and you would expect a certain coexistence just on the basis of these two diseases being, relatively common, but nonetheless, the fact that there's a 3 to 4 times higher incidence definitely speaks to the fact that they may be sharing some underlying pathological mechanisms. And interestingly, individuals who have migraine also have a higher incidence of seizures and epilepsy. In fact, a recent study found that 3 to 5% of all patients with migraine also had epilepsy, and the general prevalence of epilepsy, in the population is probably around 1% or less.
Right. So are there particular epilepsy syndromes that put people at higher risk for migraine than others?
Definitely. And this has been an area of a lot of research. It's been very well studied and well characterized. And yes, there are specific epilepsy syndromes, and the one that immediately comes to mind is the one with the complicated Greek name, the Peri-ictal syndrome. It's otherwise called occipital epilepsy. So the occiput is the part of the brain just above the neck, and these individuals have seizures which arise from the occipital lobe, and interestingly, they wake up in the middle of the night. Sometimes they vomit. They complain of a really bad headache, and their eyes may kind of twitch a little bit, and sometimes after the seizure also they may have a headache in addition to having migraine. So this is one of those syndromes where you can have a peri-ictal headache as well as a migraine headache. In fact, the headache can just be a part of the seizure itself, which makes it really difficult to diagnose.
Right.
Another syndrome that would predispose to migraine is called Rolandic epilepsy, and that's a type of focal epilepsy. You have seizure discharges coming from the temporal lobe, and it usually starts in childhood, though in adulthood there are other forms of focal epilepsy that can predispose to migraine as well. Now, in the pediatric age group, we have certain specific syndromes, and Dravet syndrome comes to mind, and absence epilepsy. So these are certain syndromes that are very specific to the pediatric age group, where the child can have a higher prevalence of migraines.
Okay. So you mentioned a possible shared mechanism. What are our best guesses as to why there might be why there is an association between epilepsy and migraine?
Well, the most prevalent theory is that both these conditions are characterized by neuronal excitability. So the neurons are the cells of the brain that, when they have electrical depolarization, it can lead to seizures. But the neurons can also get excitable and lead to changes which then the patient experiences as migraine or headache. So the most common theory, as I was saying, is what we call the depolarization theory. So, I don't want to go back to biochemistry or put anyone to sleep, but basically a cell has a membrane, and the potassium lives inside your cell, the sodium lives outside, but when that balance is disrupted, then the neurons tend to become irritable, and in some individuals it can manifest as seizures. But a similar mechanism has been proposed for migraine, especially for migraine with aura. The second theory is that both migraine as well as epilepsy are disorders where there is a transient chemical imbalance in the brain. So they're both transient. So these are disorders where there's usually a beginning and an end, and there may be a disruption in the GABA. So the GABA is a neurotransmitter. It's an inhibitory neurotransmitter. It normally tells the cells to calm down, but if the GABA pathway is disrupted, there could be either seizures or migraine. And another chemical, neurochemical that is commonly implicated is glutamate, which is an excitatory chemical in the brain. So these are some of the mechanisms. Of course, there's, with any theory, there's going to be some debate, and it's hard to do research on migraine because you really have to perform the PET scan or the MRI or the test when the individual is actually experiencing the migraine. And that's, of course, uncomfortable for the person, and it's hard to get a scan right in the middle of a migraine headache. So, of course, there are certain, barriers to performing this research.
Right. Okay. So in patients with epilepsy and migraine, can the nature of symptoms experienced during a migraine aura ever provide clues as to the location of the seizure focus, or can the symptoms of a seizure shed light on the nature of a patient's migraine?
Yes, I think it can. For instance, if an individual with migraine, usually an aura of a migraine is visual. Right. So basically they either have flashes of light or colors or zigzag wavy lines that they see, or sometimes you may lose vision for a few seconds. So that's very typical of migraine headaches. But it's also somewhat typical of certain forms of epilepsy, such as occipital epilepsy. So I would say that since the migraine aura is relatively restricted in the way it manifests itself, it would be hard to make a connection between the two, but I have noticed that individuals who have temporal lobe epilepsy tend to have a migraine with aura, which is usually the visual type.
Okay. So both seizures and headaches can have triggers. So can you discuss some common triggers for migraines and other headaches, and then also highlight some of those that are also triggers for seizures?
Definitely. So for migraine headache, as we discussed in children, the triggers can be a little bit different. Motion sickness is a big deal. In fact, recently, people had even noted that colic in a child can predispose to migraine, so that wouldn't be a trigger, but I just thought that was an interesting association. But yeah, motion sickness, so going for long rides in a car, trying to read in a car, can trigger migraine headaches in a child. Being excited for some reason, so, your 4th birthday party is coming up and you're really excited, all your friends are going to be over, and then you wake up that morning with a horrible migraine. That's not uncommon at all. So emotional reactions can be a trigger in the pediatric age group. In a teenage girl, menses can trigger migraine headaches. Many teenagers and young adults will say that their migraine headaches are fairly difficult to control around their period. So that could be a potential etiology. Food is rarely a trigger in children, so I almost never encourage families to, eliminate any foods from their diet. I mean, maintaining a diet log could sometimes be helpful, but eliminating foods is rarely helpful in the pediatric age group. And some parents ask me, and it's a great question, they ask me if video games could be a trigger for migraine headaches, and I wish I could say yes. But I'm not sure I can say that with certainty, and it's not backed by scientific evidence at this point in time. But I would say that we don't have enough evidence at this point to say that video games or TV are triggers for pediatric migraine. Now, in adults, as we discussed, the triggers can be a little bit more specific, which is actually helpful because the individual can then avoid those triggers if possible at all. Again, menses continues to be a trigger in women throughout their reproductive age group. So, if there are things that they can do to help control their menses and make it more predictable, their menstrual cycle, that would be something that would be worth doing. And of course, the classic triggers are sleep deprivation, which is common to both pediatric as well as adult. Emotional triggers possible, an adult who is experiencing stress at work or at home, who's experiencing bereavement or grief for any reason could definitely have an increase in his migraine or her migraine days. And of course, there are environmental factors which are specific to the individual. For example, today I saw a family and a child came in with his mom, and his mother says the heat is a classic trigger for her. So those are more, individual. But in adults, I would say food, certain types of drinks, red wine, certain types of cheeses, maybe certain types of foods with dye in them, would be the classic triggers for an adult. But one thing I would like to mention is that in the pediatric age group, many times families think that myopia or having to wear glasses is a trigger for migraine, and that's almost never so. So, it's not a bad idea to have your child checked out by an optometrist once a year, but, providing them the glasses will help them see better, but I don't think it would have a significant influence on their migraine. And finally, I just want to briefly touch upon environmental allergies. Because in the pediatric age group, again, it's uncommon for environmental allergies to trigger migraines. And interestingly, scientific studies have also shown that in adults, it's not a classic trigger. It may be for individuals, so everybody's a little bit different. Everybody's genetic makeup is different, and, your trigger factors could definitely vary, but most epidemiological studies have not noted a relationship between environmental allergies and migraines.
Okay. So in addition to avoiding triggers, what other behaviors and healthy habits can generally reduce the likelihood of both headaches and seizures? Well, the most important thing, and we discussed this many times today, is sleep. So it's not just the number of hours. So, a teenager or a child should ideally get 9 hours. Most adults function optimally at work with about 8 hours. And again, of course, there are people who get by with 5 or 6 hours, but that would really be the exception rather than the norm. So getting adequate sleep is very important. And the second thing is the quality of sleep. So some individuals, may go to bed at about 10 o'clock, but they may have sleep apnea. They may not be exchanging their oxygen and carbon dioxide the way they should be, and they wake up in the morning and they have a seizure or they have a migraine headache. And so the quality of sleep, if it's poor, either because of sleep apnea or because of restless leg syndrome or because of other sleep-related issues, that could trigger both conditions or either condition. And of course, I think another important thing would be compliance with medication, because when I see individuals who have skipped a few doses of their seizure medication, not only are they more likely to have a seizure, but sometimes they'll often say that they have headaches. So I think compliance, not only taking your medication, but making sure you take it at about the right time every day, whether it's 12 hours apart or 8 hours apart or at the same time every night if you're taking an extended release medication. I think these are really important. And finally, general lifestyle changes, I think, are good to talk about at this point because studies from all over the world have shown that individuals who maintain an ideal BMI, a body mass index, are less likely to have migraine headaches. And individuals who participate in regular physical activity, even if you don't need to, so even if your BMI is ideal, just participating in physical activities a couple times a week is very good for migraine prevention. And activity can either be aerobic, such as jogging or swimming, or it could be more like yoga and stretching. So those types of lifestyle changes, I think, are important. And finally, I just want to touch on caffeine, not so much for epilepsy, but more for migraine, because, yes, a little bit of caffeine is helpful when you have a headache, but if you drink or eat a lot of caffeine, I guess, mostly through the day, and if you stop it one day or if you forget to drink your latte at 10 o'clock one day, that can precipitate a fairly bad headache as well. So usually my suggestion to families is limit caffeine intake, exercise a couple times a week, try to get good quality sleep and at least 8 to 9 hours of sleep. How important is hydration? Does that play a role at all in risk for headaches?
Absolutely. I'm glad you brought that up. Hydration is super important, and we all forget to drink water through the day, and we just get so busy at our work or our day-to-day tasks or taking care of our families And again, this has been borne out by several studies, and hydration is really important to prevent migraine. But what you drink is also important. Ideally, people say 6 to 8 cups of 8 ounces, so that's about 48 ounces would be ideal. And but again, try to make it drinks which are non-caffeinated, because I think that would be more helpful. Oftentimes I advise families, if their child doesn't like water, to either try, mix it with a little bit of Crystal Light, or there's now vitamin waters and things along those lines. So yes, thank you for bringing that up. Hydration is really, really important.
Okay, great. Well, let's talk about treatment of headaches. Medications for headache can be broken down into preventive, abortive, and rescue. So can you talk about these different categories and provide some common examples of medications or classes of medications in each of these categories?
Sure. So by the time I'm seeing a patient, they've already been using Motrin or Tylenol or Aleve or aspirin or, Excedrin migraine. So these are, common over-the-counter medications. We call them over-the-counter analgesics. They can be very effective and helpful if your headaches are sporadic. So, if you have a headache once a month, it's perfectly fine to take an Excedrin migraine, and it would probably work very well. But usually, by the time you get around to seeing a neurologist, you probably have frequent headaches that are probably, impacting the quality of your life, causing you to miss work or school, or, impacting your ability to attend your children's games. So then that's when we consider preventive treatment. So it's not really the number of headache days you have in a month, though that's very important as well, but also how much the headache is impacting your day-to-day life. So if I have a bad migraine 3 times a month and causing me to miss work 3 times a month, that's a significant impact as far as I'm concerned. And so that would definitely be an indication for preventive treatment. Now, preventive treatments can either be prescription drugs or they can be natural supplements. I'm a big proponent of natural supplements, especially in children, and a common one that we use is vitamin B2, not 12, but 2. It's also called riboflavin, and it's a prescription, and you take it every day. It also has almost no side effects, and it's very helpful in headache prevention. Another natural supplement is called magnesium. Again, very few side effects, very helpful, lots of evidence to support it. And there are others such as coenzyme Q10 and butterbur, which are natural supplements which have been found to be fairly effective. Now, as far as the prescription drugs for prevention, the one that we use the most and the one that has the most evidence is called Topamax or topiramate, which is a seizure medication. So here we're getting back to how both migraine and epilepsy are so closely related to each other that even the treatment options are similar for both. So Topamax is something that we use quite a bit for headache prevention. And another option that has come up over the past few years is Botox for migraine prevention. We've been using it for the past about 5 years, and a lot of our patients are very satisfied with the Botox. The advantage is that you don't have to take something every day. It has very minimal side effects, and it's relatively painless. It's a very, very fine needle that we use to inject the chemical into the muscles. It's not into the brain, just the muscles of the forehead and the temple and maybe the neck. So that's really made a big impact. And finally, I would say about 6 months ago, the FDA approved a drug called Aimovig that you inject yourself just once a month, so just one shot once a month, and it prevents migraine. So that is a huge leap forward, and I really think a lot of our patients are going to be interested in this treatment. Now, as far as the abortives and the rescues are concerned, we do encourage people to use Aleve or Motrin or naproxen if it's helpful and if they found that using it provides relief. But as I said, usually by the time the individual goes in to see a neurologist, or in fact their internist, they may already have tried those options, in which case we have several very good rescue medications. And as a group, they're called triptans, and just because the drug ends in the word triptan, so for instance, there's sumatriptan, there's rizatriptan, there's almotriptan, you get the idea. So there are about 10 of those medications. And we can choose one depending on the individual's preference. So, if there is a person who says, I have a lot of vomiting during my migraine, I can't really swallow a pill, then rizatriptan would be great because it's just a meltable. You just put it on the inside of your cheek or in your lip or in your tongue, and it melts, and within 5 minutes it's all dissolved and it's absorbed. So that would be a good option for somebody like that. On the other hand, if you have someone who says, I need immediate relief because once I get my migraine, it goes to a 10 out of 10 in about 20 minutes, there are self-injectable triptans, so the individual can just use like an EpiPen, and usually there's relief again within about half an hour. But the key to using abortive medications effectively is to recognize that a given headache is a migraine headache, and to use the medication as early in the process as possible, because the longer a person waits, the less likely the medication is to work.
Okay. So you mentioned topiramate and also divalproic sodium or valproate and gabapentin are a couple of others that I've seen that can be used for prevention of migraine and for epilepsy. Can you give a few examples of situations in which you would consider using one of these medications to treat both epilepsy and migraine in the same patient, and maybe some instances where you wouldn't?
Oh, absolutely. So Topamax is the one that has the most scientific evidence to back it. It's FDA approved for treatment of both epilepsy and migraine. So Topamax is great for individuals who may, have frequent migraines, and their epilepsy is the type that would respond to Topamax. So as you know, there are different types of epilepsies, and Topamax is fortunately a very broad spectrum anti-epileptic. So it could be used for somebody who's got focal epilepsy or for somebody who has generalized epilepsy. So it really is, in a way, a perfect go-to drug for a neurologist. And the thing about Topamax is that it leads to some weight loss. So if there's someone who, would like to have that as a potential side effect, because it does suppress your appetite, Topamax would be a good choice for them. But on the other hand, one of the side effects of Topamax is that sometimes it leads to some mental fogginess. It's uncommon. I think it's gotten a bad rap, and I don't think that it's completely justified. But sometimes Topamax does lead to some difficulty with finding the right word or the ability to substitute one word for another, which is interesting. So some high school students, when they hear that, they say, well, that may not be a good drug for me. But definitely Topamax is a wonderful drug. I use it quite a bit in individuals who have both epilepsy and migraine. Now, you mentioned valproic acid or Depakote. That's an old standby. As neurologists, we absolutely love it. It's one of those medications that's been around for over, maybe 30 years, definitely as long as I've been a physician. And Depakote is a wonderful broad-spectrum anti-epileptic. So it could be used for focal epilepsy, temporal lobe epilepsy, generalized epilepsy, occipital epilepsy. It's very rare for Depakote to make things worse. There are certain situations, such as, well, we don't need to get into that, but there are certain situations where Depakote can make seizures worse, but that's rare. It's few and far between. And it's also an excellent drug for prevention of migraines. However, a major caveat with valproic acid is that in teenage girls, it should be used with caution because in addition to causing some hair loss, It can also lead to polycystic ovarian syndrome, and that would not be a good side effect in someone who is in the reproductive age group. And so sometimes we shy away from Depakote only because of that, just because the side effect profile. But in boys and in men, I mean, that's definitely one of my go-to drugs. So Depakote is a really easy drug to work with. Now, I found that Trileptal or oxcarbazepine could also be a good drug, both for focal epilepsy and for migraine prevention. It's not one of my go-tos, but when I'm in a tight spot and, I have a patient who doesn't respond very well to the standard medications, I've tried Trileptal, and sometimes I've had a good response to it. And finally, we get to gabapentin. Gabapentin came out into the market as a seizure medication, and rightfully so, because it acts on the GABA pathway, which is an inhibitory neurochemical in the brain. But over time, we realized that it wasn't a very strong anti-epileptic. Fortunately, the pharmaceutical industry could salvage it and use it for headache. So I do use it for children and adults with migraine. And the most common side effect, however, is some drowsiness and a little bit of weight gain. So that combination, sometimes scares people off. So we don't normally use it when we really need good seizure control. But if a person has good seizure control but just needs something extra for their migraines, gabapentin is a great drug because it doesn't interact with any of the other drugs, and it's real easy to administer. So that's gabapentin for you.
Okay. So neuromodulation or neurostimulation is another option for the treatment of migraine, but the specific devices used for migraine and epilepsy are different. So can you talk about the similarities and differences between neurostimulation for migraine versus epilepsy?
Absolutely. So these are good options, especially when a person doesn't really want to take a daily medication or has experienced significant side effects to medications, or in the case of epilepsy, if they've been intractable and the seizures are really hard to control with medication, and if surgery is really not an option for a variety of reasons, the neuromodulation can be a really good option. Now, for individuals with migraine, the one that's FDA approved is called the Cefaly unit, and that's CEFALY. So the Cefaly unit is like a little band. You put it around your head and kind of tighten it, and stimulates the nerves which emerge from just between your eyebrows. Those are called the supraorbital and the supratrochlear nerves. And it's been found to be very effective. I've had mixed success with it. I have some families who really like it and others who say they're really not very fond of it. But ideally, you start using it about 10 minutes a day, and you're supposed to build up to, more than that, maybe an hour a day. Some people just don't like the feeling of it. They say it's uncomfortable. It's not something they can really tolerate. But the good thing is that it doesn't have any adverse effects. It doesn't cause sleepiness. It doesn't cause mental fogginess. It doesn't interact with any other medications that you may be taking. And it's relatively inexpensive. It's about $300, which I think is a good price for a transcranial magnetic stimulation device. It's also called a TENS unit. Now, as far as epilepsy is concerned, of course, we have the vagus nerve stimulator, and that's been around for several years, and the VNS can be a very good option in individuals where the seizures have been intractable to medications, or where side effects have been problematic, or when surgery is just not feasible because there's more than one seizure focus, or the family is not mentally prepared to undertake surgery. So VNS could be a good option. We have lots of children and adults who do relatively well with the VNS. The battery nowadays lasts for about 5 years. But the difference between the Cefaly and the VNS is that the Cefaly unit you take off at the end of the evening, whereas the VNS is implanted into the muscles of your chest. It's a surgical implantation, so it can't really come out. So, some people don't like the fact that it has to stay in there for several years. But most people do well with it because the wire is invisible to the outside, and you can feel it, but usually it's not a problem. And besides some minor side effects, such as a little bit of a hoarse voice or some coughing, most people don't seem to have a lot of side effects related to the VNS. Now, interestingly, there is a device called the external VNS. So that's not something that you implant by surgery into the chest, but you just kind of hover it over your throat. It's also called a gamma core device. And that is something that we have been using in individuals with migraine. So the principle is the same. You're stimulating the vagus nerve, but the way you do it is just a little bit less invasive for individuals who have migraine. And of course, for epilepsy, there are other neuromodulation things, such as the RNS device, but those are a little bit more invasive.
And is there any evidence that VNS, RNS, or DBS actually helps with migraines as well as epilepsy?
Well, the external VNS is very helpful for individuals with migraine, but it's external, so it wouldn't help with the epilepsy. But there are some studies which show that the implanted VNS can actually reduce the frequency and intensity of migraine headaches. There are small studies. The number of individuals studied is small because it's a very small group of individuals. But yes, there is some evidence that the implantable VNS, in fact, can have benefits which can extend beyond epilepsy, including on mood and things along those lines.
Okay, great. So you'd mentioned a couple of supplements that can be used in the treatment of headaches and migraine. Are there other sort of palliative therapies, things that are just sort of home remedies that are helpful in just managing pain associated with headaches?
Absolutely. I think that a lot of alternative medical options can be helpful, and I have a lot of families who do well with acupuncture or acupressure. Some individuals have needle phobia, so they're not fond of acupuncture, but they respond nicely to the acupressure. And there have also been some studies which show that acupuncture can be very helpful for the treatment of a variety of pain, in addition to headache. And the good thing about acupuncture is that you're not introducing, any drugs or chemicals into your body. It's a painless procedure. I just kind of went in a few years ago just to experience it for myself. It's actually quite relaxing, so it doesn't cause any discomfort. And the other option could be physical therapy for individuals with migraine or headaches. I've found that physical therapy, when instituted in a regular manner, going once a week or twice a week, can be very helpful with pain control. And finally, I have some families who swear by essential oils or things along those lines. So I would say that if it's something that's non-invasive and helpful to yourself or your child, it's definitely worth trying.
Sure. And I'm sure families have probably asked you about CBD as well. Is that any because
yeah.
it's if you go online, it can help with everything. So, but is there any actual evidence that it could be helpful for migraine or headache or pain in general?
Yeah, in fact, I just made a note on my little scratch paper. I just wrote down CBD oil, and you just happened to ask me that question. So, yeah, cannabinoids have, the receptors are extensively distributed throughout the body, not just the brain, but, there are CBD receptors in multiple areas of our body, including our gut and our heart. So with such widespread distribution, it's plausible that it can have effects on multiple organ systems. And even in the brain, it's very widely distributed in areas which may predispose to both seizures as well as migraine. Now, of course, with epilepsy, we have some well-validated studies in children who have certain forms of epilepsy where certain forms of CBD can be very helpful, certain strains, or even the new drug which came out into the market, the Epidiolex. Now, in individuals with migraine, the evidence is not as robust, and especially in children. We really don't have any idea of what the long-term implications of using daily CBD oil would be. There's quite a bit of concern that it might affect cognitive function and intellectual abilities. And when a child is young, that's the last thing that we want. And of course, even for an adult, most of us have to be intellectually very sharp during the day when we're, performing our day-to-day work or parenting or doing other things. So I think the use of CBD oil seems to be more established in the epilepsy realm at this point in time.
Okay, great. So general neurologists can, in most cases, treat both migraine and epilepsy. In some cases, though, subspecialty care might be needed. So in epilepsy, subspecialists are called epileptologists. But what does subspecialists or subspecialization in headache involve, and how can patients go about finding a headache specialist?
All right. Yes, you're right. A general neurologist can definitely address both epilepsy and headache in a very effective manner. And epileptologists are, of course, board certified in epilepsy by a national board. And there's also, interestingly, a board for headache. And I'm, in fact, a board certified child neurologist, and I have a special certification in the treatment of individuals with headache. So basically, after you finish your medical training and you finish your neurology training and you finish your pediatric neurology training, you have an extra year of fellowship in headache medicine, during which time we learn about different procedures such as Botox, external VNS. We also do some research in the area of headache medicine, and I think that nowadays there's so much more awareness about different types of specialties, no matter whether it's headache or epilepsy or multiple sclerosis or no matter what. A good way to locate a headache specialist or to find somebody who has special expertise in headache medicine is either to go to the National Headache Foundation website, where they have the list of people who are board certified in every state in headache medicine. But again, I want to emphasize that you don't necessarily have to be board certified. It's definitely a stamp of approval, but I definitely know many general neurologists and pediatric neurologists who are experts in the treatment of both pediatric and adult migraine.
Okay, great. What other healthcare professionals might be involved in the treatment and management of headache besides neurologists?
Well, there could be pain specialists. We often work very closely at Children's Hospital with our pain specialists, and the pain specialist is usually an anesthesiologist, though they could be a neurologist who's done special training in pain medicine. And many of our pain specialists are experts in doing special procedures for headaches. For example, they could do nerve blocks, or they could inject local anesthetics into certain parts, which would help with the alleviation of headache. Or another specialist could be a physical medicine and rehab doctor, so our PM&R doctors, as we call them. We work very closely with them at Children's as well. They help me with many of my Botox clients because they're very familiar with use of Botox. And then finally, we have some very good advanced practice providers, physician assistants, nurse practitioners who worked in the field for decades, and I would definitely consider them experts in the field as well.
Sure, great. So other than epilepsy, what are some of the comorbidities associated with migraine?
Yeah, that's really important to address, and I think we're kind of running over time, but I will quickly mention that many individuals with migraine, no matter whether you're an adult or a child, can have certain psychological comorbidities. The most common of which is in the pediatric age group is an anxiety disorder, which can manifest as a generalized anxiety or anxiety to specific situations. Panic attacks are common. Depression is common in both individuals with migraine as well as epilepsy, and it's not causative. So in other words, it's not the epilepsy that's causing the depression, but it's the underlying biological mechanisms which are common to both conditions. Another condition, I think, which individuals with migraine may be predisposed to, or no, I wouldn't say predisposed, but association. There's often an association between obstructive sleep apnea syndrome and headaches. So, we spoke a lot about quantity and quality of sleep. So in a lot of my migraine kiddos, if I see that sleep is something that needs to be addressed, I'll be quick to perform a sleep study and start talking about that as well. And of course, sleep is vital for epilepsy as well.
Great. And are standard treatments for anxiety and depression typically safe for someone who has both migraine and epilepsy?
Well, it depends, because there are certain medications which can lower the seizure threshold. There are certain medications which work well, and there are certain medications that even help. For instance, many of the benzos, the benzodiazepine group of medications, such as the Valium, the Ativans, the Xanax, those all belong to the benzo group, and so does Onfi or clobazam or clonazepam. So some of them can actually be helpful, but I think sometimes having the input of a psychiatrist can be helpful, because as neurologists, we are familiar with those drugs. We definitely use them, but in more complex situations, I do consult my colleagues in mental health.
Great. Okay, before we open it up for questions, do you have any closing thoughts on this topic that you'd like to share?
Well, if you have epilepsy, or if your child has epilepsy and they're complaining of frequent headaches, which appear to be more than just your run-of-the-mill headaches, I think it's worth taking seriously, because it could very well be migraine, and addressing the migraine could vastly improve the quality of life, both for you and your child. And so, that's something I think patients don't necessarily bring up when they see their epileptologist, because they think, well, we're here for our epilepsy control, and that's all we're supposed to be talking about today. But we are more than happy to address issues other than epilepsy, no matter whether it's migraine or mental health conditions as well. So I would encourage people to bring up these topics when they go to meet their neurologist.
Great. Okay, who'd like to get us started with a question?
This is Marissa.
Yeah.
And I just have a quick question, because I got a flood in my basement and I got to tend to.
Oh, no.
But I want to find out. Now, I've taken the Topamax and various other medications you talked about, but I want to find out your opinion about Lyrica.
Okay, well, I'm sorry to hear about your basement. I have personal experience with it, and it can be a nightmare, so I'm really sorry to hear about it. Now, yes, Lyrica is pregabalin, so it's a GABA derivative, and it can be definitely helpful for individuals not only with migraine, but also those who have chronic pain syndrome, such as fibromyalgia or musculoskeletal pain syndrome. And I have had good experience with Lyrica in individuals who have both migraine and epilepsy.
Okay.
The only problem with Lyrica, though, is sometimes it's hard to get insurances to cover it. They seem to be very resistant to the idea, and I've had to jump through a lot of hoops to get Lyrica approved. And I think the key word to use is fibromyalgia. They seem to approve it if you say that.
Okay. Because many years ago, I was experiencing bad headache pain, and I've been on the Topamax and various other things. And at one point, the doctor had put me on the Lyrica, and I can only be on it for a short time because it swelled up my hands and my legs. I had swelling a lot, so I had to get off of that. And now I've been on Dilantin, and that seems to be the best thing for me.
Oh, okay. Well, that's good. Yeah. Dilantin is definitely an old drug, and we have a lot of experience with it. We have decades of study, so yeah, well, that's good. Yes, Lyrica does do that. That's definitely one of the side effects. It can cause some swelling, yes.
Yeah, it did. Okay, well, thank you. I enjoyed, your presentation and everything, but I got to go because I got to get there, help get this water out my basement.
Oh, I'm sorry about that.
Yes, you do. Thank you, ma'am.
Okay, you all take care. Bye-bye.
Okay.
Bye-bye.
All right, other questions?
Hi, I have a question.
Go ahead.
Go ahead.
Oh, I'm sorry. Hello. Thank you so much for your presentation. I have a question. I'm on several anti-seizure medications. I have complex refractory epilepsy and catamenial epilepsy. So I take a over the FDA dose for Topamax. I take Onfi and I take Vimpat. And I'm also using all of the different vitamins that you had recommended for headaches because I've been getting migraines. I'm 48, so I've been getting, I think what you described as the migraines right around my menstrual cycle, which is suppressed with a birth control pill. Mm-hmm. So in my case, would you recommend doing some more aggressive treatment then? Based upon what you said, because I can't take Advil. It affects my GI system. So would you recommend some more aggressive treatment?
Sure. Well, thank you for your question. And yes, catamenial epilepsy, I don't know if you and your neurologist have ever tried a drug called Frovatriptan. Frova is FDA approved for catamenial epilepsy because catamenial migraine. I'm sorry, now let me clarify. Are your seizures worse around your period, or are your migraines worse around your period, or are they both worse around your period?
Well, I have seizures randomly throughout the month. Okay. I don't have seizures any longer around my ovulation and period because they're suppressed with my birth control pill. But instead of the seizures, I get severe headaches all week long. And then I also get severe headaches around my epilepsy. So pretty much I'm having severe headaches pretty much all month long. So. Oh,
I see. Then in that case, I'm sorry. Go ahead.
No, and I can't take anything for it, So it just, I just have to bear it. And I have a high pain tolerance, but it's just getting worse and worse. So.
Oh yeah, that definitely sounds like it would be a very difficult situation. But have you ever considered Botox, ma'am? I think Botox would be perfect for somebody like you because your insurance would likely approve it because you failed the vitamins and you're already on the Topamax at a very high dose and you failed that. And most insurance companies, and believe me, I worked with them. I mean, I think I've worked with pretty much every insurance company out there, and most of them stipulate that you have to fail 2 or 3 different options. And in your case, I think you've done that because you failed the Topamax and you failed the B6 and you can't use a non-steroidal, and I think that you would be a perfect candidate for Botox if that's something you'd be willing to try.
So one option is Botox. The other option would be, you mentioned something else. There was another one.
Mm-hmm. There's a new drug which came out. It's called Aimovig. That's A as in apple, I-M-O-V-I-G, Aimovig. And I really like Aimovig because it's self-administered. You give it to yourself just once a month, just one shot, and it comes in 2 different strengths, 70 and 140 milligrams. And in fact, it's less expensive than the Botox. So many insurances are willing to go the Aimovig route, and evidence to support it is fairly robust. And I've used it in about 8 or 10 individuals so far, and most of them have been very pleased with it. And it does not interfere with your seizure medication because it acts on a specific target in the brain that only mediates migraine.
Okay. Well, that's good to know. All right. Thank you. I really appreciate that.
Great.
Well, thank you for your question.
And someone else had a question?
Okay. Thank you.
Earlier?
I did, Russ. I was wondering if during your treatments there, if ice or heat would be a good treatment also during a migraine.
Absolutely. That's a great question because a lot of my patients, they say that using an ice pack is really helpful, but I have a handful of patients who say that taking a hot shower is helpful. I personally think that ice would be more effective, just looking at it from a pathophysiological viewpoint, because I think that ice would probably lead to some vasoconstriction, which may be helpful. But yes, I mean, I think an ice pack is something that a lot of individuals with migraine find useful to place on their forehead or in their neck if they can tolerate it. Because some people with migraine just can't tolerate anything on their head or in their neck during the episode. I had a lady who couldn't even wear a scarf. She couldn't wear a set of pearls during the migraine because it was so painful. But if you can tolerate it, I think an ice pack is a reasonable thing to try.
Well, I use I take rice and I put it in a old sock and I'll throw it in the microwave for 1 or 2 minutes, and then I'll put it on my head, because a lot of times my eye will feel like I have like an ice pick in it. I'm on Trocandy XR, and that seems to really help my migraines.
Absolutely. Trocandy is a wonderful drug. It's, I mean, you're lucky that your insurance is covering it.
I know. I know.
You are
and
lucky.
It's really, yep, I know I am. And it's really helped with my finding my words and everything too, because I was on Topamax, the regular there, and I had a hard time with that. But it's really helped my migraines big time. Big time. But
that's great.
Yeah, and for those who aren't familiar, that Trocandy XR is an extended release version of topiramate. So.
And may I ask what dose you are on, ma'am, for the Trocandy XR?
I'm on 400 milligrams a day.
Ah, that's a hefty dose.
Yep.
Yep, that's a hefty dose, but
and
it's working for you. That's good.
Yep, and I haven't had any seizures, and I've just been on it since October.
Wonderful.
So,
touch wood.
Yes, I am. Yes.
Okay. Other questions? Anyone else? Okay. While you think about it,
I do have a question.
Yeah, go ahead.
I do. I was prescribed Aimovig, and I am still having daily migraines. But some days it goes from like a scale of 4 to an 8. So I just don't know what to do with my daily headaches. I mean, there's not a day that goes by that I don't have a headache.
Now, do you happen to know the dose of your Aimovig? Are you on the higher dose, the 140 milligrams? If you happen to have it, you can look at it. But if not, that would be the first step, because most of the times insurances dictate that we start with the lower dose. And usually, if it doesn't work in 2 months, I jump up to the higher dose right away. And you might already know this, but the FDA has recently approved another MAB, as we call it, because they all end with the word MAB. And they just recently approved another one. And I haven't personally tried it, but I've had some conversations with my adult neurology colleagues, and they've found that, some of the patients who don't respond to the Aimovig do respond to the other antibody drug.
I do believe I am on the lower dosage.
You may want to speak to your neurologist and see if he or she would be willing to try the higher dose. I would. I mean, I think that you have nothing to lose. It's severely impacting the quality of your life, obviously. And I think at this point we really need to look for the most effective option.
I mean, when my headache is at a 2, I just say that I don't have a headache.
Right, just because you're so used to having, being in pain all the time.
Yes, that's exactly how I feel.
I know, and I'm sorry to hear that.
Yeah.
If you want, I can give you the name of the other FDA-approved medication if you happen to have a pen.
Yes, I do. I've been writing a lot of your things down through the whole presentation. So
okay.
Thank you so much for your presentation.
Oh, you're most welcome. You're most welcome. This other medication is called eptinezumab, so I'm going to spell it out. It's EPTINEZUMAB, and this just got approved in March. So, it's brand new for all of us.
It is brand new.
So as neurologists, we're trying to learn as well, but, it's something that's out there, and I think it's on the market, and for somebody like you, I would go for it.
Well, thank you so much. I appreciate that.
Absolutely. Take care.
Thank you.
Bye-bye.
Bye-bye.
Okay. So I actually have a question. Someone had emailed me a question regarding hypnic headaches. These are pretty rare, but from what I understand. But this person had tried the caffeine before bedtime, which is the kind of standard approach to prevention, and it worked for a little bit, but then they've returned, and they're basically happening every night. He wakes up in the middle of the night and also has migraines, and the migraines are being effectively treated, but just wanted to know what other options there might be for the hypnic headaches.
Great. That's a very interesting question, and I'm just going to, say a few things about hypnic headache, just because not everyone may be aware of it.
Sure.
It's also called an alarm clock headache. So basically, it wakes you up at 2 a.m. or 3 a.m. or 4 a.m. every night. So you can see it can be very disruptive to a person's life, and tends to start in middle age, maybe in your 40s. Or thereabouts, and it's got a completely different biologic mechanism than migraine headaches. And yes, caffeine is typically what we try, but I have found some success with melatonin with hypnic headaches. So melatonin, as you know, can be purchased over the counter in the United States, and I usually start for an adult. I presume this person who has emailed you is an adult.
Yes.
Okay, then I would start at 3 milligrams and do that for a couple of nights, and if it doesn't work, I would go up to 6 milligrams. I've had 2 patients over the course of my career. They were both adults who had hypnic headache, and they both had a fairly good relief with melatonin. So I think it's a safe option, and it would not interfere with any of the other migraine medications or even epilepsy medications if this person happens to be taking them. And it's over the counter and relatively inexpensive.
Great. Thank you so much. Okay, we've got about 5 more minutes or so. Any other questions?
Russ?
Yeah.
Are you coming to the summer stroll at Potter Park Zoo?
Potter Park Zoo? I believe I am, yeah.
Great. I will see you there.
Okay, great.
All right, I have a question.
Yeah, go ahead.
Oh, okay. I was just curious if the doctor can share any insights of the connection between gastrointestinal issues and headaches.
Oh, yes. Really, really important, and I'm so glad you brought this up. I mean, nowadays there's a plethora of information about your gut biome, basically the microbes which live in our gut, and neurological conditions. I mean, all the way from migraine to multiple sclerosis, and of course the most research has been done on multiple sclerosis. But the bottom line is that now we know that the flora that live in our gut really do have very, very significant impacts on several areas of our life. But having said that, now in terms of, are you specifically asking in terms of symptoms or treatment with probiotics, or like lactose-free type treatments or gluten-free type treatments?
Really just, I guess in general, I'm calling, I have an adult daughter who has seizures, and we have found that through treating her gastrointestinal issues, while it's a long-term process and we still have a ways to go, but treating her gastrointestinal issues have improved her epilepsy and also her headaches significantly. We have been in the past through different pharmaceuticals and, of course, over-the-counter options, and, and, of course, CBD, THC as well. And here we are finding that at age 22, maybe if we would have known about her gastrointestinal issues years ago, she perhaps never would have had so many headaches, and maybe perhaps never would have developed epilepsy. So I guess I get so discouraged when I hear presentations from doctors all over the world, and there's just pharmaceutical after pharmaceutical after pharmaceutical after pharmaceutical, and you don't hear very much about let's treat. Where is the culprit? Where is the culprit to the inflammation?
Absolutely.
So I would love to hear a neurologist say that they're working with gastroenterology.
Oh, yes. In fact, I'm really glad. I'm sorry this came up at the tail end of the presentation. I wish we had addressed this earlier, but no, I completely agree with you. In fact, a lot of my migraine patients first start out going to the gastroenterologist because, they have the abdominal migraines, just the belly aches, and, they get treated for reflux and gastritis and this and that. And then they realize, no, these are actually migraines starting in your belly. And, of course, constipation, you're probably familiar with that. I mean, constipation can increase migraine headaches, and it can lead to problems with how your medication, your epilepsy medication is absorbed as well. So definitely, I think GI issues are really important. I think we haven't directed a lot of money and resources, intellectual resources, to studying this, but now they are. I mean, with MS, with multiple sclerosis, there's a huge push to looking at the gut biome and the effect it has on the immune system. So I think from now, the research is only going to spread, and I think there will be some interesting breakthroughs with respect to both migraine and epilepsy, as well as our gut flora. Absolutely.
Okay, great. So we maybe have time for one more question, if anyone has one. Okay, and does anyone, I also wanted to make sure if anyone has something they wanted to share in terms of something that you have used that hasn't been mentioned that has been particularly helpful for you in dealing with migraine or other types of headache.
Absolutely. I would love to hear that too, because, we learn a lot from our families and patients. So absolutely.
So, does anyone have anything that's been effective that hasn't been mentioned? All right. Well, I guess you did a really thorough job of covering all the options. So, all right. Well, we will go ahead and wrap up the call. And thank you so much, Dr. Sivaswamy, for an excellent call. Very challenging topic and expansive topic. So you really covered it well and gave people a lot of options, a lot to think about. So if people do have any other further questions, please contact Epilepsy Foundation of Michigan at www.epilepsymichigan.org, which is our website, or call 1-800-377-6226. Our next Learn and Share conference call is entitled EEG 101, so kind of an overview of EEG and how it's used. That's on June 5th from noon to 1:30 p.m. So thanks again, Dr. Sivaswamy, for an excellent call, and thank you, everyone, for joining us tonight.
Wonderful. Thank you, Russ, for organizing it. And, it's a perfect time to end because now we can all go and watch Jeopardy.
Perfect.
Thank you very much.
Thanks.
You're welcome. Bye-bye.